Okay, so at the end of the session, like I said, you'll be able to ask questions. I would like to share my personal story with you. I was diagnosed with stage 4 metastatic breast cancer 15 months ago. So October of 2017, I finally received the referral, which took 3 months, from my primary care provider. I begged my primary care provider for a biopsy. I received a letter from the HMO that said, oh, you know, you have dense breasts, and when they read the repeat mammogram, they said, oh, come back, it's probably nothing. And I emailed my doctor and said, I'm concerned. And anyway, the referral came in after me documenting in an email that the pain level was 8 and I need the referral. And so I was diagnosed with stage 4. To the liver, you have to advocate for yourselves, as you know by this point. And now I'm in really good hands. I have a great relationship with my oncologist. So I encourage you all to continue to build your relationships with your oncologist. I also have a subtype called inflammatory breast cancer. And some of you have heard me mention some of the questions. I'm trying to advocate for doctors and staff to take continuing education units so that more will focus on that part. But right now, we'd like to introduce Dr. Samina Ahmed. Dr. Samina is from Rush Medical College, where she also received her medical degree from Rush Medical Center. She's practicing as a hematologist and oncologist right now at Kaiser Permanente, and she's been there since 2011. So she strives for excellence and developing a healthy relationship between patient and provider, and keeping opening lines of communication. I'd like to introduce Dr. Samina Ahmed. Thank you.
Thank you for that introduction. Good afternoon, everyone. Again, my name is Dr. Samina Ahmed, and I'm a medical oncologist and hematologist at Kaiser Orange County. And it is truly my privilege to be spending this afternoon with you discussing the management of lung metastasis. So let's go ahead and get started. So if we first start with looking at the metastatic pattern in breast cancer, the SEER database from 2010 to 2013 identified 7,862 patients with metastatic breast cancer. And as you can see, if we divide that metastasis out by site, lung was the second most common at 30.3%. If we look further then to divide the patterns by subtype, we can see that the most common subtype is hormone receptor positive, HER2 negative, followed by triple positive, HER2 positive alone, hormone negative is the last in that subtype. And if we then put the two together and look at having the lung as the only or solitary metastatic site, you'll see that it is the second most common for hormone receptor positive and triple negative subsets. So when we talk about lung metastasis and the possible presentation, typically symptoms include a persistent cough, chest pain, which it can also include pleuritic chest pain, which is chest pain when you're taking a deep breath, shortness of breath, dyspnea on exertion, which usually means shortness of breath while you're doing some kind of an activity like climbing stairs, and unintended weight loss. And typically, the diagnosis is made after some type of imaging that shows abnormality. So in my first picture, the one on the left, we see a nodule in the left upper lung. In the picture on my left, a nodule in the right lower lung. So then as we talk about the pulmonary evaluation, so if there is some imaging that shows that there's a nodule that's growing, typically the next step is to biopsy. And what I would want to emphasize with that is the importance of repeating receptor testing. And we'll talk about that more in just a second. If an imaging study shows a solid nodule, typically the characteristics we're looking at for attempting a biopsy is at least 8 millimeters or bigger. And this is sometimes a discussion that involves a multidisciplinary approach with your radiologist, with your pulmonologist, because as you may know, one of the biggest risks to biopsying lung tissue is that you can cause a pneumothorax or collapse in the lung. And that's why as we get to the third point, when there's imaging that shows a partly solid nodule, sometimes it is very reasonable and appropriate to repeat a scan. Because again, in metastasis, it'll typically be a solid nodule. And so if the imaging is showing something where there's a nodule component and then whatever is described as wispy sometimes, then that can be a little bit problematic, because when you try to attempt that biopsy and that wispy go into the wispy material, again, you may cause untoward complications like bleeding. And so can be very reasonable option to repeat imaging at a shorter interval scan. And if that has grown, or you see that, no, now that looks really solid, then it is worth doing the biopsy. Okay. And now I really want to emphasize the importance of receptor testing. There was a study that analyzed a cohort of 627 patients who had developed metastatic disease. And what they found is that 30% of tumors had changed from being a primary hormone receptor positive tumor to hormone receptor negative. 21% of tumors had changed from a primary being hormone receptor negative to hormone receptor positive. About 6.5% of tumors had changed from being HER2 neu negative to HER2 neu positive, and about 4% of tumors changed from being HER2 neu positive to HER2 neu negative. So now as we come to, well, how do we approach treatment? So I think the biggest strategy we have in treatment when someone develops a lung metastasis or has a recurrence to the lung is the importance of getting systemic control. Now, again, our understanding of cancer is not complete, but the theories are that this spread has occurred via cancer cells through the lymphatic system or hematogenously through the blood system. So the concept there is we need to get systemic control, because sometimes if we limit our thinking to, well, we'll just attack the area of the lung and just focus on that, we may be missing other sites that may pop up a few weeks, a few months later. And this is where I think it's very important to understand sort of the evolution of treatment. If there is someone who is having a lot of symptoms with their disease because of the metastasis to the lung, whether it be shortness of breath or cough or limited exercise tolerance because they can't walk a few steps without getting short of breath, then again, our goal is to gain control rapidly and quickly. And typically our best option to do that is with chemotherapy. And in terms of where things have evolved, we still have our traditional chemotherapy options, right? The anthracycline, the doxorubicin, which is known as the red devil. We still have our taxane, the one that causes the neuropathy. That still can be the backbone of treatment in metastatic disease. But where we have more options is that there are a lot of chemotherapy agents that are effective in breast cancer and in the metastatic setting. And the ones that I've listed, the eribulin, the ixabepilone, the navalbine, these are the treatments that have been shown to have response even in patients who are heavily pretreated. So third line, fourth line, fifth line treatments, we're still looking at response rates between 20 to 45%. If we look at treatment in another way and look at it by treating by receptor subtype, I would say that there has been an evolution in this as well. So typically with our hormone receptor positive patients, the backbone of treatment was hormonal blockade. Get rid of the estrogen and the progesterone. And typically with our postmenopausal women, that was with aromatase inhibitors. And the advancement that we have now is that we're understanding that maybe we shouldn't just have a one-prong approach. And can we hit the tumor and the cancer cells in two ways? And what's come out now is these CDK4/6 inhibitors, or cyclin-dependent kinase inhibitors. By inhibiting this protein, it leads to the activation of a tumor suppressor gene, which causes cell cycle arrest. So now we have treatments working together through two pathways to attack the cancer cells. And what have we seen? That, well, with the combination, you can increase progression-free survival by over 10 months. If we look at the HER2 neu positive pathway, as HER2 neu receptor was recognized and then treatments were developed directed against it. The backbone with that treatment has been trastuzumab or Herceptin. And how has that evolved? Well, now we're finding that there are different combinations that we can use. So it's not just Herceptin alone, but Herceptin and Perjeta or pertuzumab, which is dual HER2 blockade. Or we're looking at TDM1, which is a combination of trastuzumab and an anti-drug conjugate, which is shown to be effective when Herceptin no longer works. And combinations of trastuzumab or Herceptin with an oral HER2 blockade to get some benefit. Even, I would say, in the triple negative setting, and I think this is probably one of the more exciting settings as well, because we were so limited with what we had for triple negative disease. And recently, the FDA has approved atezolizumab, the PD-L1 inhibitor. And what are we seeing? We're seeing that while we add immunotherapy to Abraxane or backbone chemotherapy, that we're having improvement in progression-free survival and overall survival. And of the different subtypes in breast cancer, the one that looks to have most promise in terms of having this immunotherapy option seems to be the triple negative subset. And now we're opening a new array of potential treatments in this category. For those with the BRCA1 or 2 mutation, again, we have a new drug with the olaparib, the PARP inhibitor, finding another way to target the subset. So I think that, again, the strategy then is to develop systemic control. And once we've effectively had systemic control, there may be a rogue element. So you have everything under control, but gosh, there's still that tumor in the lung that's growing a little bit. So that's where I really do think that these local treatment options come in. And one of the standard treatment options has always been anatomic resection or surgery. There isn't a lot of data for this, unfortunately, because I don't think it's an area that has been studied very effectively. But one of the single institution reviews that I found of 81 patients who underwent resection, those where the surgeon was able to remove everything, all the margins were clear, there was no evidence of any cancer cell, that patient group, 81% of those patients had a median overall survival of 103 months. For those where most of the tumor was able to get out and you had some microscopic or macroscopic cells left, 18% had a median overall survival of 20 months. And when you tease out that data to look at, well, what was important in driving the survival, the factors that came up that were important is that the survival was better if that tumor expressed the hormone receptors. It was better if there was a single metastasis that you were targeting to remove. And the survival was better when the tumor was less than 3 centimeters. Another area in terms of a local treatment option is radiofrequency ablation. And that is when an electrode is placed in the tumor using image guidance. It's coupled to a radiofrequency generator, which produces a voltage and electric field with the concept of heating tissue to cause cell death. The ACOSOG Z4033 study evaluated the safety and effectiveness of doing this in patients who are deemed inoperable. And what they found is that the overall survival at 1 year was 86%. The overall survival at 2 years was 68.9%. The local tumor recurrence-free survival at 1 year was 68.9%, and at 2 years was 58.9%. And in this study, what they did see is that, again, the smaller the tumor, the better the response and effectiveness of the treatment. So if we're thinking about where local treatments have evolved, while surgery, radiofrequency ablation still seems a mainstay, I would say that the area where things have evolved is with stereotactic body radiotherapy. And in this treatment option, what's happening is we're utilizing precisely targeted radiation to a tumor and trying to minimize the collateral damage or the radiation damage to the adjacent normal tissue. Again, Not a lot of studies for this data, but if we look at single institution reviews, in 121 patients who had 5 or fewer lung metastasis, the 2-year local control rate was 77%. The 4-year local control rate was 73%. What was interesting is that they did report that you could use this treatment as an additional alternative if there was a recurrence and still have control. So I think this was the treatment that I was most intrigued about. The chemotherapy options that we talked about, the targeted options, that's what I do as a medical oncologist. It's the radiation oncology field that I didn't have such a good grasp on. So when I talk to our radiation oncology colleagues, granted that we are trying to establish this across multiple radiation treatments through Kaiser, in the review that they're doing, there were 3 patients with metastasis to the lung, and they have reporting an 87% local control rate at a follow-up of 19 months. So in conclusion, what I'd like to say, in the world of medical oncology, I would say that this is a very exciting time because of the rapid development of novel treatments. And while our goal, of course, is still to cure breast cancer, in the meantime, I hope today, this afternoon, has given you a glimpse of the options that we have that we are utilizing to help our patients live longer and live well, even with metastatic disease. Thank you. So I think what I'm referring to is breast cancer that has gone to the lungs. So the tables I was showing is when we're looking at whether at the time of diagnosis, someone's diagnosed with the breast cancer, but also in the staging workup find out that, there has a lung tumor as well, so it's metastasized to the lungs. But also the group of patients where they may have had breast cancer 5, 10 years ago, they have some symptoms of cough, shortness of breath, imaging is being done, we see a mass in the lung, it's biopsy. The biopsy is consistent with the metastasis from breast cancer. And again, that's where I would say it's so important that when you're getting that tissue to make sure that they do repeat the receptor testing, checking for estrogen receptor, progesterone receptor, and HER2/neu, because now with these developments of the new treatments we have, the new treatments that are coming down the line in the future, targeting the cancer that way is going to be a very important way or strategy to control the cancer. Right. So that's always, a question that my patient asked me at the time of diagnosis. I think it really depends on how you're looking at things, right? So technically, the concept is that with stage 4 disease, you can't cure. And this is what I tell my patients, that our goal is to control the cancer. And in doing so, you have to look at it as a marathon and not a sprint. And as I was talking with Carlitha a little bit earlier, I think it's a mindset change, right? So what our goal is at this point, until we have a cure where everyone can be cured, the mindset change should be, can we make metastatic disease a chronic condition? Yes, there's going to be treatments you need for it. Yes, you're going to be on it long term, but can it be as automatic as what people think about treating their diabetes or their high blood pressure? So, and then I'll just sort of allude to the other part of your question. So for example, if I do have a patient who has metastatic disease to the lungs where they, let's say, have multiple tumors, what I tell them is, well, how you're going to do is really depending on 2 things. One, how well you tolerate the treatment, and second, how well does the treatment work? And I have to say, I have quite a few patients that with our combination of the aromatase inhibitors and the CDK4/6 inhibitors, that I've had lung tumors that disappear. I've had lung tumors that are stable, that haven't grown, and no new stuff for over a year now. And again, that's not even using chemotherapy, which is what we traditionally thought about, that, oh, if the cancer goes to the lung or the liver, it's moving fast and hit people with chemotherapy. Not to say that we can't do that. That's an option, but that's where every case is a little bit different. And where I would say that this is where the art of medicine comes in, right? You have a whole list of treatment options potentially, but then you have to find, well, okay, where is that balance about treatment? Getting that treatment with respect to everything else you need to do in your life, right? Being able to handle those side effects of treatment and giving that treatment some time to see, well, how did it work? And if it didn't work, moving on to the next thing. So I do think that in the metastatic setting, the mindset, and this is what I try to emphasize with my patients too, is that we're thinking about this long term. How can we control this disease? And there's going to be likely a lot of treatments we go through to try to do that. And so balancing the benefits of whatever treatment we're going to start with the side effects in the context of everything else about your life that you need to do that's important to you is the key and the goal. I can describe it with the rudimentary knowledge that I have of it, again, not being a radiation oncologist. But my understanding is similarly to RFA, they do place a probe in the tumor. What it is you're doing concentrated radiation, so it's a higher dose, but at a fewer interval. So it may be 3 treatments or 4 treatments instead of, commonly after breast cancer, we have 5 to 6 weeks of radiation treatment. So what you're saying is you're going to deliver a much higher dose, but much more precisely. Now, where it can be applied to bone metastasis, I'm not sure. The patients that I've had and again, when we're looking at the balance of why we're using radiation as a treatment option, typically for bone metastasis, it's in the setting of someone is having a lot of pain, right? So pain control, or look, their bone has so been weakened by this tumor that there's a risk of fracture, and let's stabilize it. I have not had an experience yet with patients who've had stereotactic to the bone. Typically, mine has been, traditional external beam radiation. But that, again, since everyone is different, is something that is worth asking about. So I think that is also very patient dependent, right? So what are your risks and benefits in both options? So you have one tumor, right? When did that tumor come? Was it shortly after adjuvant treatment? Has it been 15 years? Because that also gives you a sense of, well, what is your cancer doing? Because again, like try to emphasize, all breast cancer is not the same. Okay, so my approach and my concern, so if my patient had brought that up with me, is, we're seeing one, but what about the other cells we don't see? Going back to, again, we don't have a precise measurement of it. So is it worth starting something systemic and trying to control all the cancer cells wherever they may be, the ones we can pick up and the ones we can't, and getting response that way, versus saying, look, it's been 5, 10, 15 years since your breast cancer. We had this one area pop up. Let's consider CyberKnife to that. I think those are both equally reasonable options, but again, it goes back to the history. Because what the concern would be is if we say, all right, you have one lung tumor, let's just target that. What the risk is, we put you through the CyberKnife, and granted now, the CyberKnife, which is the stereotactic, are similar terms for the same type of treatment. Great, we were done in 3 days, 4 days, right? So we didn't put you through the whole weeks that we maybe necessarily had to do before. But what happened in the next month? Did 2 more lung tumors pop up? So again, going back to sort of putting everything into perspective as, how has your cancer behaved? And it may be very reasonable to say, well, I don't want to do a chemotherapy or even this aromatase and palbociclib, another oral chemotherapy combination because of its side effects. And maybe we start with CyberKnife and see if it behaves. And then, your cancer or the disease will declare itself, right? A month later, You may have 2 more nodules pop up and we say, okay, well, look, we gave you a month where you were still able to do whatever you wanted. You were worried about the side effects of that, but now look at it. We don't have that choice. Because again, I think what the data represents is if you're going to target for local treatments, the smaller the tumor, the less the number, the highly successful that's going to be. But the question comes back to how is your cancer, the rest of it, going to behave? So when a cancer does metastasize, you treat it the way you treat the primary cancer. I would say there can be oncologists who have a certain focus, right? So again, my focus is breast cancer, and that's my interest. But I think that we're very lucky that there's a lot of organizations. So the American Society of Clinical Oncology, there's the National Comprehensive Cancer Network, the NCCN, which provides guidelines. So I would say that we're very lucky that when it comes to treatments and treatment options, there are a lot of resources that people have to say, well, what can we do in this? I will say, though, that that's the good thing. And then again, when we talk about double-edged sword, that there's no right answer, right? There's not black and white. And so even when I talk about, hey, these are our list of treatments, what's the right treatment for you right this second? Well, it's a balance of, well, what are the side effects of the treatment? What is that going to entail in terms of, do I have to come into the infusion clinic or my chemotherapy clinic to get it versus it's an oral medication? What are the symptoms that you're having? So I would, I agree with what was said earlier, that it really is that you have to build a relationship with your oncologist or your physician. And I think that's true, period. I think the era of someone or a physician or whoever telling you, oh, this is the way we're going to do things. There's so many things out there now, there's no right way to do it. And I think that you have to, and this is what I would say for myself when I'm looking for a physician, right, or a provider or whoever I'm going to, you have to find someone who has a balance between the science and the data, and then understanding that everybody is unique, everybody's cancer is unique, everybody's lifestyle and what their priorities are and what they need to do for their life are unique, and then having those examples of, well, what are the possibilities that we can do? And if we do this now, well, what would we have later? And make it a more thoughtful discussion instead of a conversation of, this is what we're going to do. So there is a change in our mindset, I would say, not my mindset, the researchers, because I don't do research and lab research, but the mindset change is, look, in the past we gave chemotherapy, right? And the point of the chemotherapy was, let's target these dividing cells. But gosh, it would have been great if those chemotherapy molecules had radar or sonar, so they just went to the bad cells and they didn't kill off the good cells, so people didn't lose their hair, have issues with their taste, have the nausea, vomiting, diarrhea. And so I think that, again, where the evolution is coming towards cancer treatment in general is targeted treatments, right? That instead of just doing a quote-unquote shotgun approach, can we target specific pathways, okay? So that's where things are moving. But I think where you have to be careful is that different cancers will respond to different treatments in different ways. And so, for example, in lung cancer, if the tumor has PD-L1 expression, the first treatment for a metastatic lung cancer can be immunotherapy, provided the patients fit that condition. So that's been a very exciting, revolutionary concept, data across the cancer world. But then it's been, okay, where can we use it, right? And so right now, what the data is showing is probably the triple negative population is the one that will have the benefit. And again, where the recent FDA approval showed that the first immunotherapy drug that can be used in breast cancer works in the metastatic triple negative patients. So I don't think we have data yet for hormone receptor positive and HER2 positive patients. So while we're trying to do more personalized medicine and targeted treatment, the concept is, well, what's going to be the success of that cancer that we're treating? Responding to it. So basically, when we have to code, they don't have the nice things like we want to say. So we have to fit whatever is the closest to what it fits. So malignant neoplasm means cancer. To the lung means it went to the lung. So typically, again, it's a way of how you code it. When I'm coding a patient, I'll say metastasis to the lung. But it's the same thing. It's just wording. No, I think that again, it goes with how the cancer behaves. So there's some women who, when they find out they have the breast cancer, they also find out that the breast cancer has already spread to the lung or to the liver and to the bone. And there's some women who've had their breast cancer, got their surgery, let's say their adjuvant chemotherapy, did their hormonal blockade, and years later, they had another mass in their lung. And whenever you have a mass, which again goes back to the importance of biopsying, why that's crucial, because that tells you that no, it is a lung cancer or a breast cancer. So here we're talking about those that are breast cancers, but then you also repeat the receptor testing, because a woman who had her initial breast cancer where it was hormone receptor positive may, at the time when she finds out that the cancer went to the lung, find out that it's not hormone receptor positive anymore. Typically, and again, I don't know the exact data, but I don't think there's a lot of, and again, this might be because we don't kind of count it or look for it, of metastatic breast cancer in male patients. In my personal experience, yes, I have male patients with breast cancer, but they have not metastasized. But just going back to your other comment that yes, we women get breast cancer because we have breasts, but similarly, men get prostate cancer because they have prostates, right? So.
Well, we'd like to thank Dr. Samina.